Hello, my name is Dr. Lindsay Page, and I am a faculty member at Baylor College of Medicine. I also work at the Michael E. DeBakey VA Medical Center. This is a set of series developed with the Southeast Texas Geriatric Workforce Enhancement Project, the SEDEX-GWEP. This is the first in a three-part series, specifically, providing dementia education to the LGBTQ community. We'll get started here. This is our first lecture in the series, Dementia 101. A little bit about the Southeast Texas Geriatric Workforce Enhancement Project is that it is a organization that works on a national level to improve geriatrics education across many disciplines. Here in Houston, we work with a lot of the different institutions within the medical center to kind of provide education and get a lot of people excited about working with the older adult population. So this specific project was in partnership with the Southeast Texas Workforce Enhancement Group, as well as with the Montrose Center. This is the first part in the series, part 1, and it's Dementia 101. And actually, that's my name's Dr. Lindsay Page, and now I'm actually a geriatric psychiatrist, no longer a fellow. And this was made in partnership with the Montrose Center, and a special thanks to Richard Gomez, Nicole Sullivan, Bertie Nunez, and Jennifer Queen, who all helped in kind of planning and gathering the materials for the series. And the series is really meant to kind of provide dementia education to the public, and specifically the LGBTQ community. And this first part in the series is talking about the basics of dementia, what it is, what is the evaluation, what are the treatments, and then next we go into care planning and caregiving, and the other parts of the series kind of go throughout different parts of dealing with dementia and what comes after the evaluation and preparing for the long-term things that can kind of happen alongside dementia. Care planning and caregiving are a huge part of that too. So we'll get started. Here are our objectives. At the completion of this session, participants should be able to describe the signs and symptoms of dementia, list at least 3 common forms of dementia, and recall at least 3 risk factors for dementia. And they'll summarize the steps involved in the diagnosis of dementia and be aware of the commonly available treatment options. And then as we go through, we will kind of always come back to our agenda, so we make sure everyone is following along with us where we're at and kind of guiding. This will help guide us through so no one gets lost. So first, we'll define dementia and its signs and symptoms. Now, the nature of the talk is really geared towards the LGBTQ community. And so I think in any time as we're going through the presentation, this is kind of terminology that we're going to be using. We use the LGBTQ umbrella, and then but within that we say that the L is for lesbian, G for gay, B bisexual, T transgender and queer, and then of course now they're LGBTQ plus, LGBTQIA. We don't want to leave anyone out under this. In this presentation, we're trying to make it inclusive and not exclusive. Oftentimes too, with the Q and for queer is really now becoming more of a term for anyone who kind of differs from the norm of what society feels as sexual orientation and gender identity. So a lot of times, another term we'll use is sexual and gender minorities, because this is a group of anyone whose sexual and gender identity, orientation, or practices differ from the majority of the surrounding society. And so as we go through and use the acronym, this will be what we mean as part of the acronym for LGBTQ. Of course, this is by no means, unfortunately, not listing everyone that really falls under that and everyone who identifies as a sexual and gender minority. And so sometimes we like to use that other term instead. All right, and so getting into dementia. Dementia is a general term, it's an umbrella term that really is meant to mean a progressive impairment in thinking that interferes with daily life. And by definition, it cannot be a normal part of aging and the aging process. And throughout the presentation, we'll have a lot of different great infographics, alz.org. I'll make the plug now, alz.org. The Alzheimer's Association is a great place to go for not just education about Alzheimer's dementia, but they have education about all different types of dementia, and a lot of great resources that we'll kind of talk about too in the different presentations that we have through the series. But here, as we can say, dementia's umbrella term used to describe a wide range of symptoms, including memory loss and decline. And these are a couple of different types of dementia, which we'll come back to as we get through the presentation. Here are some of the signs and symptoms of dementia. Now, these may not all happen in the beginning. They might not all happen in the middle. Some of them will happen in the beginning, the middle, and the end, I guess is what I'm trying to say. And because our brain is made up of different ways, different parts of thinking, so memory is only one part of our thinking, language is another part. And so different dementias can affect different parts of the brain at different times. And so sometimes people start with memory loss, but sometimes actually people start more with this problems with language. Or sometimes the first thing people notice is actually more issues with judgment. And so these are just some of the signs and symptoms of dementia to look out for. Memory loss, difficulty performing familiar tasks like bills, making lists, maybe using your phone, getting on the internet with online banking or something like that. The third, I don't remember, or actually it's problems with language, maybe just like in this graphic, kind of misputting letters in different places or missing words, exchanging words that don't mean the same but sound the same. Disorientation, forgetting the time, the date, getting disoriented, changes in judgment. So it's like, maybe someone's on the phone and giving someone some money they don't know, whereas maybe before, maybe some of the dementia, they might have never done that before. And so kind of changes in judgment there. Problems keeping track of things, misplacing things, withdrawal from social activities or work activities, trouble with images and spatial relationships, becomes a difficulty with driving, changes in mood and behavior. And again, by definition, it's not a part of normal aging. And so these are our 6 domains of cognition or thinking. And so like I mentioned before and on the previous slide, memory is only one part of the thinking domains we have in the brain. So these are kind of all the different functions of our brain, and these are kind of the 6 common domains, and they kind of also take part in different areas of the brain that do different things. So executive functioning, planning, decision-making, a lot of that is our frontal lobe. A lot of this language is sort of frontal and temporal. A lot of the learning and memory is in temporal, but then of course, a lot of these domains actually, different parts of the brain do help out with different domains. So not every domain is kind of unique to one part of the brain, because language can be, of course, frontal and temporal, perceptual motor, sometimes in parietal and occipital lobe. And so by definition for dementia, one of these areas has to start showing a significant decline. And so that's why these are really important. And also, just one thing to note again, that some dementias actually start out with not memory, but maybe language issues, maybe planning issues. Memory might not get impaired until later on in some types of dementia. And so we've gone through defining dementia. Now we're going to explain the different types. And so again, here's our nice umbrella of dementia again. Again, the most common type of dementia is Alzheimer's dementia. That's about 50 to 75%. We think vascular dementia, which comes along usually after stroke or after multiple strokes. We think of that as a second type. Lewy body dementia is a type of dementia that's related to Parkinson's disease dementia. They're two different, but similarly, with Lewy body, you can start off with kind of sleep issues and hallucinations, visual hallucinations, and later kind of comes some of the Parkinson's symptoms with issues with walking and chewing and movements. And then frontotemporal is a bit of the most rare. This is one where there's a specific type of frontotemporal dementia, primary progressive aphasia, where you can actually start off with having language issues before even having the memory issues come. And then there's alcohol-related dementia, which you can imagine comes after drinking an excessive amount for a long period of time. There's Parkinson's disease dementia. This is usually someone is diagnosed with Parkinson's, and then years later, they end up developing the dementia. And so they start off with the movement issues, and actually the memory issues come later. Not everyone with Parkinson's disease does end up having dementia as well. Something to note. And then Huntington's disease, this is a rare neurologic condition. It actually starts out with some psychiatric symptoms early on. It's highly genetic, so usually there is a family history as well. And then they have psychiatric issues really early on, and then usually end up developing the cognitive and the thinking issues, memory issues later. And then of course, HIV-associated dementia is something that can happen to anyone who has HIV, but usually more often if someone's not been on antiretroviral or HIV medication for a period of time, and that allows the virus to kind of cross the blood-brain barrier, get into the brain, and that's how it really ends up causing dementia. And so because Alzheimer's disease is the most common type of dementia, we'll start there. It comprises an estimate about 60 to 80% of all cases of dementia. These are some old statistics that we have, but the CDC estimated about 121,000 LGBTQ older adults who are living with Alzheimer's in the US in 2011 through surveys and data they were able to collect. We always usually estimate that a lot of our statistics with the LGBTQ community are usually underestimates, because historically in society, it has been hard for LGBTQ people to necessarily feel comfortable identifying themselves on public surveys or coming forward in these kinds of health-related studies as well. There's a buildup of proteins in the brain. That's what we think causes Alzheimer's disease. And there's a lot of research ongoing right now that is looking at medications and therapy that can target this process. So we can target this buildup of proteins in the brain. Maybe we can stop it early before it gets to the point of the dementia. And so because those proteins build up in the brain, they take up space, they're not supposed to be there, they start this pathway of killing off the brain cells, and then that's how the dementia develops. In the early stages, patients show difficulty in language and memory historically. And then in later stages, they end up having difficulties with language, social cognition, which is kind of like reading humans, like how we read each other, how we see, how we respond to each other with our nonverbal language, with our language, and those kinds of things. And then executive functioning, which is that frontal lobe functioning that's really important with planning. Of course, it's really important when we're driving, when we're doing our finances, when we're doing those like complex daily tasks. Usually our instrumental activities of daily living require a lot of that. And then behavioral and psychological symptoms of dementia, BPSD will abbreviate. They are usually often in the middle stages. And this can comprise of, sleep issues, depression, anxiety, sundowning sometimes. We're just in that afternoon, evening time where people might tend to get more confused. They might wander more. They might need frequent reorientation of like where they're at and what's going on. And the vascular dementia is the second most common type of dementia. Like I'd mentioned before, it's usually caused by a bleeding or clot in the brain resulting in stroke. symptoms are related to that area of the brain in which the stroke happened. So if it was in my frontal lobe, I'm going to start having issues with that planning, that executive function, that inhibiting myself. So I might be more likely to do something I wouldn't do normally because I don't have maybe that frontal lobe telling me, stop, hey, you're at work right now, it's not time to yell, or something like that. And so if I have the stroke in an area where my language is, then I might have issues, getting my words out. If I have that stroke in my temporal lobe or my occipital, better example, I might have issues with my vision or something like that. And so wherever the stroke is where usually the issue, wherever the stroke is usually is where we see that part of the brain have an issue. And so over time, you can imagine this can become dementia if that impairs so much of our thinking domain, then it becomes dementia. And usually we call it stepwise, because as someone has more strokes, it brings them down another step. And they're kind of additive. So the more strokes they have, the further steps they go down. And unfortunately, the more function they lose and the higher likelihood of dementia. And so in Lewy body dementia, like I had mentioned before, there is a similar process than to Parkinson's disease. Just like with Alzheimer's, we think of this dementia as like there's a buildup of this protein in the brain that we can't get rid of, and then it builds up and it shouldn't be there. And so the brain says, oh, let's kill off those cells where it's at. But unfortunately, then that leads to a deficit in our brain. And so usually it does start with changes in sleep and then visual hallucination. So people see things that aren't there. Historically, it's things like small children or animals. It's very unusual though. And then of course, people end up coming to see a mental health provider usually. And that's where we say, this isn't like another mental health condition. Unfortunately, we have to start thinking about dementia because we know we have to kind of be able to differentiate those. And then it usually progresses as the dementia goes along into more of the Parkinson's symptoms. So they get more of the movement and balance issues, and then of course more memory issues. Yeah. And then these are the less common forms. We mentioned the frontotemporal lobar dementia. As you can see from the name, it starts frontal and temporal lobes usually. There's different types, but one type, like I mentioned earlier, does affect language more and early on. Another type actually affects more the personality and the mood more first, and then goes on to affect more the memory and language. We're learning more and more about mixed dementia, which we think more people have than we diagnose, maybe, which because there's likely more than one process going on, maybe Alzheimer's and vascular dementia. That's really the two that I see most common in my work. And usually what's most helpful to really tease this out is when we work with neuropsychology and we get some testing done to really help us see which one of those domains is the one that's most affected. And we'll talk about that a little bit at the end. And these were the other types that we mentioned. And so now we're going to explore the course of dementia. Excuse me, I'll find my slides again. We'll explore the course of dementia, and we'll discuss the risk factors of dementia after that. So we're exploring the course now. And so as you know, probably each dementia is going to have a different course likely. So we're going to kind of talk in general terms about the course of mainly Alzheimer's is what we'll focus on in terms of the course, but it's important to just make a note that each dementia kind of might have a different course along the way. But before all dementias, there is a diagnosis called mild cognitive impairment, which is not dementia, but it's getting to be more and more thought of as maybe the step before dementia. Now, what we know about people who are diagnosed with mild cognitive impairment is that not everyone that has this diagnosis goes on to have dementia. Some people stay here, just stay in this mild cognitive impairment. It's not a part of normal aging by definition, and it's not dementia, but it's somewhere in that middle. And some people just stay there for the rest of their life. They don't progress and they don't get better. Some people actually get better and go back to kind of normal aging. Some people do go on from here to develop dementia. And so, as you could tell, we might want to look, and that's what a lot of research right now is looking at. What is this MCI area? Like, is there anything, what if we could capture someone here and then prevent them from going into dementia? So there's a lot of trying to figure out what it is about this stage that we don't know already. And these are common things that kind of we see in MCI, off losing things, forgetfulness, trouble finding words when talking. And so usually the course, so again, like each dementia affects someone differently, and then each person might be affected by dementia differently. So again, this course is very general, but at least for Alzheimer's disease and Alzheimer's dementia, we like to think this is a really wide range, but the course is usually 2 to 10 years from the time of diagnosis. So you might say, wow, that's a really big range. What's going on there? Well, a lot of times I think what's happening is, unfortunately, people aren't getting the diagnosis till they're maybe in moderate stage, or sometimes even in like moderate to late stage, teetering on that edge. And that has to do a lot with maybe how we diagnose dementia and whether or not we have enough education in dementia so that our primary care doctors or people who are seeing patients more frequently, are they able to make this diagnosis? It's a huge diagnosis to make, and it does take time, energy, and in our healthcare system, oftentimes those are things that those are precious resources. Time is a big precious resource in our current system. And so I think this is why we have this big range, and hopefully as we get better at diagnosing and better at catching things, we'll be able to kind of make that a more precise measure. And so in early dementia, we see a slight decline in memory and ability to think clearly, and it does interfere with daily life, but most people are still able to function independently. They may have more compensatory strategies set in place. They may have a family member, friend, loved one, chosen family helping with things. But for the most part, they can live or they can function independently. This is also a really great time to take control of planning. Do you have your medical power of attorney? Do you have your financial power of attorney? Is your will done? Is an advance directive in place? Have you talked about what your wishes are in this sense, in the case that if you can't make your own decisions, who would you want to do that? And this can be incredibly important for the LGBTQ community, seeing as in the state of Texas, if you don't have your legal documentation in order, it will go straight to your family by genetics, your sister, brother, your parent. And so in this sense, the LGBTQ community who may have more chosen family, it'd be really important to kind of start the planning, start getting those legal documents in order, just so it's made sure who you want to make decisions for you is in place and everyone knows, and all that legal documentation is ready to go. And so in the beginning of early dementia, we have domains affected like memory and language, executive functioning and attention, and then of course language like trouble expressing or organizing thoughts. And this is where things can happen with difficulty managing finance. So maybe a loved one is taking over for some of those more complex tasks. And in moderate dementia, there is now not a slight, but a significant decline in memory. they need more and more assistance and support in their daily lives. They cannot function independently and often need help from caregivers and aides. They need assistance in most of their instrumental activities of daily living, like finances, medication, transportation. They're getting lost in familiar places. They might get suspicious or irritable with family members because maybe there is difficulty with social cognition, or they just don't remember what happened. And so there's a family member telling them over and over again that something happened, and it can be irritating in that situation if you can't remember and everyone it keeps telling you. And then you might get suspicious because you just don't remember that thing. I didn't remember I gave them $20. Now I don't have $20 anymore. Did they take it from me without asking? And then this is where, again, those behavioral and psychological symptoms come up again. Oop. Or the neuropsychiatric symptoms, another name we use. But things like depression, agitation, changes in sleep, and other mood changes. Agitation can be a lot of different things. Unfortunately, it can be anything from like irritability, wandering, and then well, actually, really, agitation as a definition should be more of the like aggression, usually physical aggression. Yeah. But it's a word that unfortunately we need to be more consistent with in medicine in terms of what it means and how we use it. So, and in late dementia, it's a further decline, causing individuals to need 24 assistance and support. There's an increased vulnerability to medical illnesses and complications because someone might have difficulty swallowing or incontinence at this point. Really, people start needing assistance in all of their activities of daily living. Yeah. And now we'll go through or discussing the risk factors for dementia. So who's affected by dementia? Remember, this talk is for the LGBTQ community. So we're talking mainly who's affected. We know that we think 2.4 million LGBTQ individuals over 65 in the US were dealing with dementia. And this mostly is from the Alzheimer's Association research they were doing in the CDC. Mostly, I think they were cold calling people, asking them questions, and trying to kind of, again, though, do we know if this is underestimate how comfortable the LGBTQ community feels identifying themselves in our current climate? LGBTQ community was more likely to have dementia and cognitive impairment. This was one study that felt that through research they were doing that there was a higher likelihood in the LGBTQ community. Some more statistics about 7%. Again, another estimate about 7% of LGBTQ older adults in the US were living with dementia then. And there was this other study that came out that said specifically, so within the LGBTQ community, who had higher rates of cognitive difficulties. So they didn't necessarily say dementia, but people who were having problems with thinking, and they identified Black, Latino, Hispanic, and HIV positive males as people who were at higher rates of cognitive difficulties. So we can talk a little bit about that and why we think that is the case. So in terms of our Black and Latino population, our HIV population, there are historically some healthcare inequities that have happened within our healthcare system in regards to not having access to care adequate for Black, Latino, HIV people. And so that is one thing. Okay, if someone doesn't have access to care, especially if the care is unequal, which is what we found through many years and we're trying to kind of undo and improve, then the overall health is not good, and overall preventative care is lacking. And as you can see, many of the risk factors for dementia are things that definitely you need preventative care for: high blood pressure, diabetes, heart disease. And so if we're not getting care to all of these, race and ethnic minorities, then of course they may end up with a higher rate of dementia, because we're not addressing these risk factors. Now that's something that we need to, I don't know that we've had specific data looking at, but that is kind of a hypothesis in thinking about all of this. So these are the risk factors for dementia. Of course, age, as we all age, we become more at risk for dementia. Genetics, there are a lot of the different dementias that have some genes that we can inherit through our family. Sedentary lifestyle has been found to be a risk factor. Obesity, smoking, race, ethnicity, diabetes, high blood pressure. Certain race and ethnicities have higher risk factors. Alcohol, HIV/AIDS, head injury, or traumatic brain injury, and social isolation. And so there's a note on this that they have found that these are higher rates in the LGBTQ community. And so that might also be a reason why, okay, if these risk factors are at higher rates in the LGBTQ community, then, does that make them more at risk as well for dementia, because there are all these things. There's also, the minority stress model, which might also probably, in general, all minority populations having a certain amount of stress, just being in that place in society, healthcare inequities, but also maybe institutional barriers to maybe getting a better paying job, or getting healthcare that they need, insurance that they need through that better paying job, education in the area they live in, a lot of things like that. And then, of course, I think one thing to really note is the social isolation here, especially with LGBTQ older adults who may be more likely to be estranged from their family of origin, end up having, hopefully a family by choice of loved ones. More and more, though, combating social isolation is important, and combating loneliness, because we're learning more and more about that and its link and risk factor for dementia. And then reviewing the steps in the diagnosis and treatment options for dementia. We'll do that now. So dementia is a clinical diagnosis. There are many pieces involved in reaching that diagnosis. It's not just one lab test, one cognitive screen, or one exam. It's a whole lot of things we put together in order to make the diagnosis. And so that's why it takes a lot of time, effort, energy to kind of come to it, and to really put all the pieces together. And it takes a lot in a partnership between the patient, the doctor, and maybe even sometimes psychologist, a social worker, a case manager, other people that kind of help in making sure that the family's supported and understands everything that's going on. And this here is a kind of a brief cognitive screen. This is a MoCA. It is, again, just one of the many tools we might use in the dementia diagnosis. And then, of course, there are depression screens that we also usually do as a part of a dementia evaluation. This is a PHQ-9, which is for depression. There's a specific one for older adults called the Geriatric Depression Scale. Usually what a dementia evaluation begins with, it usually happens over more than one appointment, because it takes, testing and just a lot of different information being compiled. It's an interview with a family, caregivers, loved ones, people that know the patient well. We usually ask someone to come with them so we can get kind of two perspectives as to what's going on: a physical exam, laboratory tests, medication review, and then special tests might be warranted, like some imaging, like maybe a brain image. Usually we'll get at least maybe an MRI or a CT. If it's a rare dementia or one that we think is linked in genetics, we might get some genetic tests. We might, rare cases, do a lumbar puncture or a PET scan. Neuropsychological testing, that is, I think I mentioned before, specially trained psychologists who are neuropsychologists do hours-long testing. This is something that important to know. It's going to be arduous and difficult, but usually if we find on that cognitive screen, we do that MOCA from the previous slide. If we find something here that's concerning, we might then go and recommend neuropsychological testing, because that helps us really see how big is the deficit from where this person was before. The psychologist can estimate, given someone's education and background, kind of where they would be before the issue, and then we can see how much they've declined, and it can tell us really specifically which area of the brain is having problems, and it helps us sometimes come to a specific dementia diagnosis. We might know, hey, this looks like it's concerning for dementia, but until we get that testing might help us more, okay, this is definitely Alzheimer's, or this is a Lewy body, or maybe it's a mixed picture that we're seeing. And then their treatments. There's no cure or treatment to stop dementia right now that we have. Usually we really try lifestyle modifications to help slow the progression. Because there's no cure or treatment, our goal is to slow the progression of the dementia once we have made that diagnosis. So we counsel diet, exercise, good sleep habits, blood pressure, blood sugar control, cognitive stimulation. That's also talking, seeing people, socializing, doing games or puzzles, listening to music that stimulates the brain, anything that stimulates the brain. There are some medications. Aricept is a medicine. Donepezil is the brand name, or the generic name. Those are called acetylcholinesterase inhibitors. Those, again, help slow the progression of the dementia. They are for Alzheimer's, Lewy body, but not all dementias, technically, those will slow progression or help. So it's important to talk to your doctor and kind of get on the right cognitive stabilizing medication. And then perceptual and motor function. Okay, these are kind of in which domains will these things help? And so cognitive stimulation really helps this learning and memory domain. And again, the medications can do that too. And by help, really, right, slowing the progression. And, physical activity, PT, OT, physical and occupational therapy can really help with any kind of motor, perceptual issues coming from the dementia. Just talking and being with someone helps with their language. If, just stimulating all the different parts of the brain, whatever you can do is really helping keep it active and slow that progression of the dementia, slow the death of those brain cells down. And then if there are mood issues or those behavioral and psychological symptoms of dementia, then psychiatric medications can be helpful at times too. And here are many resources. The ELS.org is a great one. It has a 24/7 helpline here. And then, of course, the young and early onset Alzheimer's information. That is something to kind of look at. When I did this presentation before, someone had specifically asked about kind of this, learning about early onset Alzheimer's. That by definition, it happens before 65. And so there's just a lot of education and resources on ELS.org. You could spend hours and hours there learning different things. The National Institute on Aging also has some great education materials. And then again, the CDC, they do a lot of research and actually looking even into the LGBTQ community and what's the burden of dementia there. So these are 3 great ones. I think there are more. Okay, the VA also, we have some great research and some education there. The World Health Organization. And then these are a few movies, Supernova, Robot and Frank, and Still Alice, just about people dealing with dementia. Yeah. And this is my email if you have any questions for me. Thank you very much for your attention and listening, and hopefully you'll get on to kind of looking at the other resources or other modules that we have for you. Definitely kind of keep moving through them just to get all the knowledge you can. Thank you.